All right.
All right.
Should we get going here? Dr. Matz, are you ready? Gene, are you ready? Jessica, are we ready to get going here?
I'm ready.
We're all ready.
Okay.
Take it away.
Okay. Well, I think that I'm introducing Amar Dixit, who is the Section Chief of Allergy Immunology and the Chief Medical Information Officer at San Mateo Medical Center, located in California. He's been actively involved within our specialty in both the practice management and advocacy realms for the last several years. He has been the chair of the Alternative Payment Model Task Force for the college for the last several years and is passionate about advancing the interests of allergists and immunologists. He's a fellow of the college and the academy. He completed his training at National Jewish, where I also did several decades earlier, and is board certified in allergy immunology. He's also got an MBA from Northwestern's Kellogg School of Management. He's going to speak to us today on the episode quality improvement program, give us an overview and what it means for allergists, which I think, from what I've understood from Gene, who spoke to our society, at least a few of us, that it could be quite beneficial without much downside or really any downside. And then Gene will be speaking to us as well. He is the CEO, not the president, of our state medical society called MedChi, and has been instrumental in helping all medical specialties and physicians in the state, and especially allergists, where he was incredibly helpful 10 years ago when Kathleen May came to me and said, we got a problem. So, Dr. Dixit, take it away.
Thanks so much for that warm. Welcome, Dr. Matz. Good afternoon, everyone. Apologies for the few-minute delay here in the start time. We had a bit of a mix-up with the links, but it looks like everyone is here who is supposed to be here. So just for some background as to myself and why we are here and why I am here speaking to you guys today. I'm the chair of the Alternative Payment Models Task Force for the college. And we have been, over the last several years, working both on a local and a national level to really advance the interests of allergists, immunologists, as payment models have evolved and changed, to make sure that our voice as stakeholders are well heard and to ensure that our interests are reflected, and always looking out for opportunities that can advance both our ability to practice from a clinical perspective and our ability to make sure that we are financially viable going forward. I myself am an allergist in California. So we're going to start off this presentation. This 1 hour is going to be really in two stages here. The first stage I'll be leading off, and we'll be talking in general and high level about what alternative payment models are and how we sort of ended up where we are today. And then we'll do a really brief overview of the Maryland EQIP program, which our partners, Gene and Jessica, will be going over in further depth. And if I can advance my slides. There we go. Okay. So our objectives today are to learn about alternative payment models and why they are relevant, and to learn about Maryland's EQIP program. We're going to talk about existing payment models. We're going to talk about what an alternative payment model is, and then once again about the EQIP model and why it's beneficial for allergists. So not a lot of this should be new news to you on this slide here, but I did want to make sure that everyone was aware of some of the terminology and why we're headed where we're headed. So our current payment model historically is often based off this fee for service, meaning you get paid for each service that you provide and what you do. And this model really rewarded physicians and healthcare systems, et cetera, for providing more services, but didn't necessarily focus on providing the best or most efficient care for patients. And I know a lot of you guys have likely heard in both popular media and within our professional circles about the rising costs of care in this country, in particular Medicare spending. And this graph here sort of shows our slow but unfortunate steady rise in how we're spending our Medicare money. So up to 744 billion in 2022 compared to 200 billion in 2000. I thought it'd be important that we talk about the MIPS program. And if folks have questions during this presentation or while we're chatting, there's an opportunity for us to ask those questions at the end, but it can also be advantageous for us to pause and answer those questions as we're working our way through. I wanted to talk about MIPS because everyone here, or very likely everyone here, is already participating in MIPS. And I thought it was nice for us to recap what it is and where it falls in the entire spectrum of what's going on today. So as most of you know, the annual MIPS reporting is required for most allergists who participate in Medicare. The COVID emergency exemptions are over, they've wrapped up, and we are where we are in 2023. There are 4 categories that make up your MIPS score: quality, improvement activities, cost, and then for some, promoting interoperability, depending on your practice size. You then get a score, and this score determines your Medicare payment adjustment, which can range from -9% for not participating to a small bonus for exceptional performance. Now, what we should note that in 2021, 4.9 allergists had a penalty versus 3.4% of all physicians. So we were above the national, if you just look at, if you're specialty agnostic, we were above the average. The college has done some studies and work and extrapolated this information, and extrapolating the 2021 information to 2023 with the threshold to meet your target's going to be increasing to 82. The score is going to increase to 82 from the 60s. And making that extrapolation, we predict that at least 22% of allergists are going to receive a penalty, and that number may go even higher. It could be up to 30%. So just something to keep in mind with where MIPS is heading for our specialty going forward. The goal of the MIPS program is to tie payments to quality and cost-efficient care. The reality of it, unfortunately, is that it really causes a heavy administration burden, and there are financial penalties on practices that don't really have that much impact on the care itself. So where does MIPS fall and APMs fall, and where did this all come from? So CMS and other payers have become increasingly interested in value-based payment programs to reduce spending. And this has been a journey that started almost 15 years ago in the late 2000s, and we started to evolve. These value-based programs were designed to save CMS insurers money while continuing to provide quality care to patients. They were also intended to reward physicians who provide excellent quality, value, and patient experience by sharing in these savings. In 2019, CMS started really thinking about and implementing MIPS and APMs, which we will be talking about in a second. Now, to go further into value-based payment programs, once again, these tie physician earnings to the results that they deliver for their patients rather than the number of services provided. Fee for service, number of services provided, these value-based payment programs really tied to results. But a lot of these value-based payment programs, including MIPS, which we just discussed, have downside, or what they call two-sided risk, in which the physicians or practices take on financial risk, but also share in the savings. So physicians and practices don't just get the savings if they do well. If things don't go well, they end up having to return money. And the purpose of this is to really incentivize physicians to meet goals related to quality, cost, patient experience, and equity. And as we discussed before, if you don't meet these goals, you're going to forfeit some of these bonuses, and you may even lose a portion of your payments from payers. The thought process behind these value-based payment programs is they can benefit patients, physicians, and our payers when they're correctly structured. Now, if you want to look at sort of the categories of how payments work, I thought this graphic really captured it really well. The traditional model that we've had for many, many years is the category 1, fee for service, was really no link to value or quality. And then you have these other 3 categories, right? Fee for service linked to quality and value, these APMs, which fall in the sort of category 3, and then category 4 with this population-based payment. So really looking at 2, 3, and 4 is really where we're headed from where category 1 is. MIPS really falls in this category too, right? This fee for service linked to quality and value, really pay for performance. And that's what a lot of you guys are currently enrolled in and currently participating in. APMs, called alternative payment models, these are a type of value-based payment programs. These are really bundled payments based on disease episodes or disease states that sort of cover procedures and all the care that's entailed with that particular episode or disease state that you may be taking care of. Now, APMs have two different types of APMs. There are APMs with share savings, where you only benefit from it if you do well and you perform well. And there are APMs with shared savings with downside risk, sort of similar to that MIPS concept, where if you do well, you are able to reap some of those savings. And if you don't perform well, you have to pay a penalty or return some of what your earnings were. The program that we're going to be talking about and that Jean and Jessica will be talking about will be EQIP, the Maryland EQIP program, which is an APM program. And that program is a shared savings program. That program does not have any downside risk. And we'll be getting into some of the more details going forward. So why are allergy-specific APMs so important for us outside of potential of this Maryland EQIP program that we're going to be going into? It's because MIPS reporting is really difficult for a lot of allergists, especially those in small practices. It's complex, it's burdensome, and we've already talked about the penalties that you may have for noncompliance or if you don't perform well. We've discussed how it's likely that in this year and in the coming years, more and more allergists are not going to be meeting their targets and going to be paying a penalty. The great part is, though, if you participate in an advanced APM, you do not need to participate in MIPS, which is nice, right? You're in this APM and you do not need to participate in MIPS. And in 2024, people who participate in MIPS, practices that participate in MIPS, and physicians that participate in MIPS will receive a positive 0.75% Medicare conversion rate update, while all others will just receive a 0.25% conversion factor update. So there's a delta of about 0.5% in your Medicare conversion factor if you're an APM.
You know what? Yeah, I just want to correct you because you said the 0.75% was for MIPS, but that's actually for APM.
Sorry.
Yeah.
Correct. Yeah, for APMs, correct, and not for others. You have if you're participating in APM.
Right. MIPS participants will get the 0.25%.
Correct.
So yeah, you get an extra 0.5% if you participate in an APM. So it's a big benefit.
Unfortunately, nationwide, on a state level, local level, there are few, if any, advanced APM options for allergists, unless your practice is part of a PCP-based accountable care, which private practices really aren't. The thought process is that well-designed APMs for allergists could be a better financial option, a better way to deliver care for our patients. And these APMs are really going to be designed for areas that we sort of have control over, or that we are the primary providers for, diseases such as asthma and allergic rhinitis. And it looks like my slides froze here. So going back, as we were talking before, I just want to go back to this overview. So we have category 1, which was this fee for service where we were before, and we have these new categories, these value-based payment programs. Most of us have been living in this MIPS world. This category 2, fee for service, like the quality, where we have upside, and then we also have downside risk as well. But Maryland EQIP program, it's an APM program. It's an APM program that's designed specifically for shared savings without that downside risk. And if you're part of this Maryland APM or Maryland EQIP program, you do not have to be part of MIPS. Now, what should be noted, and these are some high-level points to keep in mind as Jean and Jessica are going to go through this in more detail. It only covers Medicare fee-for-service patients. It's not Medicare Advantage or Medicaid patients. As mentioned before, it only provides upside bonus potential with no downside financial risk, which is in contrast to the MIPS program. It is the only available APM that we are aware of nationwide that incorporates asthma care and allergies. It's approved by CMS and has little to no real associated practice administration burden, which Jean and Jessica will talk about later going forward. It really only takes about 45 minutes to sign up for the program, and our friends at MedChi will be willing to help out. Of note, you will continue receiving your normal fee-for-service during this period of time for Medicare, and the additional payments would come at the end of the year. Are there any questions? We're going to go into Maryland EQIP a bit further, Jessica and Jean will, but any questions sort of in general about APMs, value-based care programs, EQIP, not EQIP, or MIPS at this time that we can help clarify before we hand it off and go into further detail? Hearing and seeing none, I will hand it off to you, Jessica, to move forward.
All right, and just so quickly, while Jessica's bringing her slides up, I just want to say, so EQIP really is unique to Maryland, and it would not be possible without the partnership that we built over the last 5 or 6 years. And on the call today, we have Will from the HSCRC. And the HSCRC, which is the Maryland Health Services Cost Review Commission, is actually the one who applies and gets permission from CMMI through our unique total cost of care agreement with the federal government. So this is a Maryland-only program. MedChi, which obviously I'm the CEO of MedChi. MedChi has been working very closely with them to develop these programs so more physicians can have access to advanced payment models. In other parts of the country, there's nowhere near the level of access to advanced payment models that we have here in Maryland. We're very lucky. About 2/3 of primary care doctors are in the Maryland primary care program, adult primary care doctors. And we have a large number of physicians in bundled payments. I think Will told me we have more people in bundled payment programs in Maryland than the rest of the country. The other day we were talking and he mentioned that. And the third partner is who's going to present to you tonight, and that's Jessica. Jessica works with CRISP, which is Chesapeake Regional Information System for our patients. It's the Maryland HIE. It's the best health information exchange in the country, and she does all the CRISP work for us. And they're a nonprofit that's the state designated HIE and help us with all kinds of stuff. But I'm going to go ahead and turn it over to her and let her explain EQIP. But this would not be possible without that partnership and that three-legged stool. So Jessica, it's all yours.
Thank you, everyone. And yeah, let's just jump right into the program. So as Jean mentioned, I'm Jessica. I'm with CRISP, and my colleague Will Daniel is with HSCRC. But if you need anything, we like to point everyone to this EQIP at crisphelp.org. We will get you to the right place. So if there's any questions, just email that. And like I said, we'll respond. And if it's a state question, MedChi question, an us question, we'll get you where you need. Honestly, you guys did a great opening sell. So a lot of my first slides, I can probably zoom right through. But I do want to emphasize that this model was aimed obviously with a priority of reducing costs and improving quality, both in hospital and non-hospital settings. It really was aimed to be completely voluntary for all of our providers, and hopefully has very minimal barriers in order to enter the program. And we'll talk about this in detail, but it really, for the allergy type of episodes, it really hinges on the Prometheus episode grouper to define that. And again, I'll go into more detail about what that means. That's essentially sort of the background of this. All of this was talked about, but again, very physician-centric, independent of if you are employed independently or by a large hospital system. Really, we want to make sure this is open for all to participate. As mentioned, it is from a financial standpoint, upside risk only. There are some guardrails we have, such as our just savings accountability to ensure continued participation and moving towards that shared goal of reduced cost and improved quality. But from a financial standpoint, there's absolutely no downside risk. And of course, we spent a lot of time talking about the fact that it does qualify as an advanced alternative payment model. And of course, you get the benefits for participating in that as well. A little bit about timeline. So there is an annual cycle to this. The actual performance year for EQIP does run on the calendar year. So we are here talking about participation for calendar year 2024. Our enrollment period, though, is very short. It runs July and August. So the deadline for this year is Friday, September 1st. That's 2 more weeks to enroll. And we'll talk about what that enrollment means, but what needs to happen during that time frame is essentially either a practice or an individual provider needs to get into the CRISP portal and upload a list of NPIs, whether it's just them by themselves, or again, if they're with a practice, a couple NPIs, and indicate that they would like to participate in one or more episodes. And essentially that's it by the September 1st deadline. There are a few more steps that need to happen between the start of the performance period on January 1st, but really we'll focus, since we know we're in a time crunch, on that time frame for right now. I'd also like to highlight a little bit about the cycle of this. So everything here is based off of claims, so there is a certain amount of run out and lag associated with that. So from a payment perspective, you're looking at payment typically in, let's say, the September-October timeframe for the year prior. So if you choose to participate in 2024, again, probably September, October of 2025 is when you would see that shared savings if your group produces that. So in EQIP this year, we actually have a total of 50 different episodes that we have up and running, and people can choose to participate. There's a bunch of different types of episodes: chronic, procedure, acute, complications, and some that are specifically focused on the emergency department. Obviously, I've highlighted the two that sort of fall into the allergy specialty, both of which are chronic, but you can see an array of different episodes available across many different specialties. So lots of policies love acronyms. So let's just talk a little bit about some of the words you'll hear me talk about. The first thing you'll hear is me reference a CRP entity. And essentially, this is a singular Maryland hospital in which a care partner or an individual physician signs a standard contract agreement. This is an element we'll chat through a little bit more, but basically the CRP entity serves in a strictly administrative function. And it is really what is used to be able to pay out these incentive payments to the participants in the program. It's a good segue to that next one. When we say participants, what do we mean? We mean the EQIP entity. Really, that is the main participation function for the program. So an EQIP entity can be an individual physician, or it can be multiple physicians. It doesn't have to be dependent on, again, your employment. It could be two practices grouped together. It could be a subset of a practice. It's any grouping of physicians that would like to participate and be evaluated in an aggregate. And I think that's really the takeaway point there. It's at the level that we assess performance. So it's how all of those providers perform in totality in an aggregate that determines the shared incentive payment. Additionally, the entity itself receives a singular lump sum. So when you choose to participate, if your aggregate performance shows that you had savings, you get a single check to a single location. So that's sort of how you're agreeing to participate. This next little column is called care partner, and that's essentially what we're calling the physicians. So these are the people that are actually practicing the medicine and performing the care interventions. I think the distinguishing thing here is that each care partner, each provider is required to sign that standard agreement with the CRP entity. As we mentioned earlier, the care partners and your whole practice continues to receive your normal Medicare fee for service, but there is this potential for an incentive payment on top of your normal fee for service. And finally, HSCRC and CRISP, as we talked about, HSCRC is the main policy drivers and the ones who actually calculate episodes. They monitor performance and determine incentive payments. CRISP hosts the actual portal that has the dashboards that you can see both baseline performance in there, as well as is one of the main points of contact for communication across this group. And then this last little role at the bottom to point out, it's called an administrative proxy. And this is really a role for any support staff to that an EQIP entity can delegate the management of their program to. So again, this could be a practice manager, it could even be a consultant. It's whomever the entity would like to insist in engaging to help them manage the participation. And honestly, they can also do a little bit of the legwork when it comes to the steps needed for enrollment. I want to emphasize a little bit about this, the CRP entity, which is the University of Maryland Medical Center. Again, it is really the way or the mechanism that the state uses to pay providers or to pay the EQIP entities. And they really have two main roles. It's that signing that agreement with them, and they are the ones actually printing and writing the checks. We really, and by we, the HSCRC and CRIS are the ones who facilitate the interactions between the care partners, and will be the ones that direct CRP entity or to about how much they would pay. So just as a note, physicians could never have touched the hospital system. They don't need to be, they don't have privileges or any type of relationship with them in order to participate. Again, they just serve in this administrative role and are really, really helping help do that payment function. We'd like to highlight that they get no PHI information. They don't even have access to performance analytics. Essentially, they are the ones that are being told how much to cut the checks to and who to cut the checks. So they do some of the vendor management as far as ensuring the right billing address and stuff like that is set up. But again, strictly in this administrative function and nothing beyond that. So hopefully that helps explain that little odd role that they play. So how do I participate? How do we know if you're eligible? So the first is we do vet every provider that wishes to enroll through CMS. And what they do is they ensure they're licensed and enrolled in the PICO system. And we also ensure that they're using a certified electronic health record and participate with CRISP in the Maryland Health Information Exchange. The next step is really you sign up and you tell us how you want to participate. Is that individually or is that together? In that process, you select which episodes you would like to do. Again, that could be one, it could be many, and you determine where that check was going, who is receiving that that payment, or determine the payment recipient, and sign a care partner arrangement. There are thresholds for eligibility. So obviously this is based off of care provided in Maryland to Maryland Medicare beneficiaries. And for a single episode, you do need to have a threshold of 11 episodes in the baseline. And across all episodes, you need 50. So if you're only participating, let's say in the asthma episode, your entity would need 50 asthma episodes. And again, that's evaluated at the entity. So if you're participating with 7 other physicians, the baseline or that 50 volume is based off of the volume across all of those providers. If you're participating independently, again, we'd be looking at that volume threshold just for that single physician. And I did see a question. It says, why are physicians being called care partners? Honestly, it's a little bit of the terminology that we use with CMS for this to be qualified as a care redesign program. So it's really a term that's used from a contracting standpoint of who is signing the agreement with the CRP entity. So it's just sort of a policy naming type of thing. So hopefully that answered that. So a little bit about Prometheus. I talked about this as the base methodology that's being used for EQIP. Prometheus is a methodology that promotes coordination and collaboration across the continuum. It was developed or first started back in 2006 and is currently now owned by Change or Optum Healthcare. And there are 97 different episodes that have already been created and formed across these different types, which really allowed us to rapidly increase the number of episodes. So the first year, which was in calendar year 2022, we only had 15 episodes. We're now looking at 50. So that was a great thing about using this methodology. At a very high level, what the Prometheus methodology does is it uses this things called relevant cost. So unlike some other programs, it isn't true total cost of care. Of course, we start that way, but each of these episodes are built in a way that there's inclusion and exclusion costs that essentially gets to what they call all relevant costs to an episode. So, and most of this is diagnosis, so ICD-10 or CPT related, and everything that's considered not relevant is pulled out, and the episode or the providers that are attributed to that episode would not be sort of responsible for those costs. Within that relevant costs, there is what Change Healthcare or Optum Healthcare does is it does highlight opportunities, kind of putting things into 2 different buckets of typical care, and other opportunities for cost and quality improvement. They do highlight things that could be overused services or setting selection, Again, just looking at opportunities across all of those different diagnosis codes to see, where someone could first start when they're looking at care interventions. So we refer to Prometheus as this episode of care, and essentially it has 3 different time frames within their episode of care. So first is the actual triggering event, and we'll talk next about what that specifically is for our asthma episodes. But essentially, there is a unique set of either diagnosis and or CPT codes that trigger an event, and that starts an episode. Now, each of these episodes are tailored to meet, to hopefully identify those most relevant costs. So there's a pre-trigger period and a post-trigger period. Those numbers or that time frame is configurable. Most of the pre-trigger period is 30 days. So once we see that triggering event, we would look back 30 days from that triggering event and include all relevant costs to that episode in this bundle. It could be things like labs, stuff like that's probably a good example. I think I have a surgical example here, so it's a little bit more framed around that. But those are the types of things that could be included. And then it also looks at a post-trigger period. And these range from as far as small as 14 days, 6 months, or it could last the entire performance year or calendar year, which I believe is what most of the most of the allergy episodes do in this case. And again, the point there is to ensure that we're looking at all outcomes potentially or utilization that happens to that patient after the triggering event. So let's get into the 2 allergy episodes. We can send a link out later. There is a full episode playbook that lists a lot of different codes and stuff down to the details. So hopefully I'm just kind of highlighting the high level of what I say when we talk about these episodes. So the first one is the chronic sinusitis episode, and it is considered a chronic condition. So once there is a triggering event, it looks at 30 days beforehand as your pre-trigger period. We do want to note though that there has to be what's called a confirmation service to ensure that we know that this is an appropriate episode to open, given that it's chronic in nature. So we are looking after that initial trigger or event for another confirming event within at least 30 days for this episode to truly open and trigger. So just as a note there, and we'll have the next page kind of shows us a little bit. So once that event occurs, it has that confirming event as well. We'll look 30 days beforehand. And the time period that this is open is actually through the end of the study period, or the end of the calendar year for that performance period. You can see here, and again, I'm not clinical, so I apologize, I'm just going to put these up here, but these are the diagnoses codes that do trigger this event. And again, we're looking for that to occur either in inpatient or outpatient setting with a confirming event within 30 days. So that starts your episode. And then similarly, we'll look at the asthma one. Again, it's another chronic episode. It's going to be set up the same way. It has that initial inpatient or outpatient service based off of the triggering diagnoses codes, looks 30 days back, and of course needs a confirming service as well to ensure we're opening the appropriate episode. And then we look at all that relevant costs until the end of the calendar year. And again, these are the ICD codes here. Obviously, you guys can look at that, and I'm happy to send a more detailed playbook that also will show you what's included in that relevant cost that we're talking about. So a little bit about the chronic episode attribution algorithm, since it's slightly different. So as you mentioned, there is a triggering service for one of these episodes where we have that diagnosis in the principal diagnosis position. And essentially it's assigned to, the way we look at it is assigned to the physician who provides the plurality of all of the relevant E&M services across that beneficiary. So that may or may not be that first initial provider that triggered the episode. Again, we want to assign it to essentially the provider or the physician that has the most relevant care to that patient. So they could be seeing multiple different specialists. We want to make sure it's going, again, to the appropriate specialist. So once we know the plurality of the episode and can assign it, that episode is attributed. Again, all of the relevant costs are attributed to that single provider across the performance year. So now we go into some policy and methodology about it. a little bit about target price. So we do use calendar year 2019 as the baseline, and this has been the baseline for the first 2 years and will continue to be the baseline for this third performance year. And just as a note, every EQIP entity is assigned their unique target price. While you will have analytics that breaks down what that target price would look like, per physician in your group actually only gets a singular target price. And again, we trend that forward to ensure that it would be in 2024 dollars. So even though we're comparing to 2019, again, we'll account for inflation and things like that to make sure it's an apples to apples comparison. And just as a note that because we do rely on that inflation factor and we continue to get an updated inflation factor throughout the performance year, that initial target price is preliminary in the beginning of the year and would be updated throughout the year. This typically doesn't change much, but we do want to note that because it's not considered final into the end of the year. So we also want to emphasize that there's a singular target price across all the entities. So this is independent of the setting of care. So services could be provided in the hospital mainly or an outpatient facility, such as that. Again, you get a singular target price since we know that there is a significant price gap between different settings of care. And it definitely looks at the opportunity to shift to lower acuity locations when appropriate. So how does this target price work? Basically, how do I know if I'm going to get any money from this? It's sort of a 5-step approach. So the first thing that we do is at the end of the performance year, so the end of calendar year 2024, we look at the results. Really, what did it cost to do all of those episodes in 2024? And we aggregate that and compare it to the target price that you had in, using the 2019 data. If the aggregate is less than the target price, we determine that your savings has been met. In order to get a check or to earn incentive payments, we do require that at least a 3% savings has been completed in that time frame. And the main reason for that is we want to make sure the savings is considered statistically significant. So that's where that minimum threshold of 3% is applied. With that check met, you moved into this sort of middle ground of this tiered savings, shared savings. So in the very beginning of the year, when you enroll, we look at your baseline data. So we look in 2019 and say, where did you compare to the state in experience? So essentially, you're ranked on your efficiency in baseline. This rank will determine the relative shared savings that is paid out. So a higher cost practitioner, they're ranked lower, and thus a lower percent of the shared savings is shared with the group. Whereas our low cost practitioners are ranked at a higher percentile with a higher shared savings. So looking at the tercile ranking, the lowest one, if you fall in the lowest tercile, there's a 50-50 split with the state and the EQIP entity. The middle tercile, the state will pay out slightly more. So they will earn 65% of the savings, with the state keeping 45%. And finally, our most efficient practices in baseline, who fall into this top tercile, will get a payout of the savings with an 80% of the shared savings. So the reasoning behind this is, we acknowledge that if you're already pretty efficient in baseline, it may be harder to make additional improvements. So therefore, we want to ensure that there's a larger amount of shared if there are cost savings seen over that time frame. So now that we know what shared savings we pay out, we move to the third step, and we do take into consideration 3 different clinical quality scores. With all of our value-based programs, quality is an important component to ensuring outcome and that it's not entirely cost-focused. So for that reason, we hold back 5% of that shared savings, and it is essentially earned back based off of your performance on the quality metrics. So once we do that, this last step before we cut the check is we ensure that we don't go over this cap. So there is a CMS rule that a payment can be no more than 25% of your prior year's Part B payments. We don't anticipate that ever being an issue, but there is a cap there. That would be a pretty large shared incentive if that was the case. But again, there is, like I said, a max cap there. And again, so when we go through all of those steps, the HSCRC will direct the CRP entity or direct to pay out the incentive to the payment readmission source that was submitted upon enrollment. And again, as mentioned for a timeline, it's typically paid out in full as a lump sum in that 9-month time frame after the performance year ends. That's sort of the process. Okay. So DIS savings, our DIS savings policy. So I mentioned in the beginning that we, which is one of the great parts about EQIP, is that there is no downside, financial downside risk for this. But in lieu of a downside risk, we do have a DIS savings accountability process. And what that says is any EQIP entity that creates DIS savings in a performance year will be required to offset those savings in the next performance year in order to have an incentive payment. So essentially for future years, that flow chart, you'll see another bubble added in there that checks if DIS savings were produced in the prior year and for that to be offset. The second part of this DIS savings policy states that an EQIP entity can be removed from the program if they're in the lower 2 terciles in baseline, so that's 0 to 66 percentile, and they've had 2 consecutive years of DIS savings. So again, because EQIP is upside only and we are offering this AAPM status and Medicare bonus opportunity, we want to ensure that the practitioners who participate are doing so not only for the opportunity, but also to drive the cost down associated to that episode. And I think lastly here, I want to talk a little bit about the quality metrics that we talked about. So 5% of your shared savings is held back and your performance on these quality metrics are assessed. So these quality metrics are entirely claims-based. So a good thing about that is there's no additional reporting burden on our physicians for participating. As far as the quality goes, we are able to get that from claims. And we wanted to make sure that they could be used across all different specialties, regardless of what episodes that you choose to participate in, or what specialty you are, and of course had some alignment with the state priorities. So there are 3 different ones that are assessed again across everyone that is participating. So this one, it's advanced care planning, documentation of current medication, and body mass index screening and follow-up. So I'd like to highlight that the way that we look at these measures, or the way that we determine if these measures were performed, is we look at the end of the episode. So essentially for our chronic episodes, that's December 31st of 2024, we look a full year back. So all of calendar year 2024, and we determine if these quality measures were done by any physician in that year. So it does not need to be performed by the triggering provider for that episode. It actually doesn't need to be performed by a provider that's participating in EQIP. Rather, as mentioned earlier, one of the pillars here is we want to incentivize that coordination of care across the continuum with other practitioners, who may more frequently do these or provide these types of services. So it is evaluated, but I think, like I said, the methodology has a lot of opportunity for this to be done across the continuum and not solely the responsibility of the triggering provider. And finally, emphasizing timeline here, I think the big takeaway is this Friday, September 1st deadline. So that is when the portal closes for enrollment. We move into a CMS vetting and contracting phase, and unfortunately, we cannot add any additional providers outside of that window. So if there's, if you guys want to participate, essentially, here's the time, here's the opportunity. Hopefully, we can help you along that way. And once we get to that process, we'll be able to get people in, and we'll help them through the vetting and contracting phase leading up to that January 1st start. I think that was a little quick, but also hopefully not too much of an overload. If there are any questions about the program, please let me know.
The one offer I do want to make, and we're doing this for, well, now we're doing it for, it's getting to be a lot more than I thought we were going to do it for, but MedChi is setting up several EQIP entities for smaller practices. So if there's anyone who would like to do this, but maybe they don't think they have enough episodes, we are currently setting up groups for rheumatology, and we have 4 or 5 docs in that. Ophthalmology, we have 2 separate MSK bundles, one of which has 25 practices in it, and the other which is just being formed as of today. We're doing a large pain, which is going to be a couple ortho bundles, EQIP entity, and I think there might be one more. I do not have an allergy one set up. All I would need would be one allergist who'd be willing to be the lead care partner, and then we can do the administrative stuff. So if for some of you who are smaller practitioners or nervous, MedChi is willing to help out. And Jessica and I have been doing calls, and we will be doing calls with anybody who needs it to help you guys get set up for this if you want to be an EQIP entity and do it directly yourself. So we just want to make sure you're aware of the opportunity, because it is a really good opportunity for physicians. Does anybody have any questions?
Yeah, no, Gene, that's really a good, a nice thing. You know, for chronic sinusitis and asthma, most practicing allergists within, 2 or 3 weeks are going to hit their number, even an individual. It's diseases, we see a lot of the same thing over and over. So, depending on their population, though, these, if they qualify, but there are still some small groups around. So hopefully somebody that is in one would be willing.
Well, even if you're just nervous about doing it and you want to partner, we'd be willing to help you partner. It doesn't matter. For some of the other bundles, it can be hard for a small practice to hit them, and that's really why we're doing it. But again, we'll help any way we can. And if there's anybody who wants to sign up, but the bottom line is there's no downside risk to the physician practice at all. The second thing is that in MIPS, if you're really good, you're lucky to get a point, maybe. And that's if you're really good. It's a lot of work. You're guaranteed 3.5% if you're in the APM for calendar year, for the 24 performance year. So that's not an insignificant amount of money, because I suspect a lot of your patients are Medicare patients. So that'd be essentially a nice increase in your payment on that. So it really is a good opportunity, and signing up is not that complicated. It really is not that hard to make an EQIP entity and do it. Once you determine who the lead care partner in the practice is going to be, you can assign an administrative person, and they can sign up, and we will help you. MedChi and or CRISP and even the HSCRC, any of us will help you with whatever problems we run into. We really want people to participate and take advantage of this.
And I just want to add one note. Baseline, of course, as I mentioned, is calendar year 2019, but that does not mean the providers that are newer or do not have volume in 2019 cannot participate, but they simply need to participate with someone who does have enough volume in 2019. So again, you have someone new that joined your group within the past couple of years, please include them. I think it's a good opportunity for them as well.
Or Jessica, if it was the case that I moved to Maryland in 2020 and I'm setting up my own practice in 2020, and I don't have any patient cases or data from 2019. If there were to be a MedChi facilitated EQIP entity, they could then participate through that MedChi facilitated EQIP entity, because that would contain allergists that had practice in 2019 here. Is that correct?
Yeah, that would be, I think, a great opportunity or a good example of why the MedChi entity might work well. Like I said, they're partnering with someone else, because individually by yourself, you wouldn't be able to meet that 50 volume threshold.
And in fact, that's why we're setting up a second MSK or lower back entity, is because there's some folks who are new practices that can't do it otherwise. So the one thing I will say is, if we set up an allergy entity, we will need an allergist with enough episodes to do that. But again, I would encourage you to do it directly with your own practices and not do it necessary. I just think it's a nice opportunity, and it's a good way for you to, particularly if you're taking the penalty, it's a good opportunity. I mean, if you're taking the penalty, the delta is 11.5% on your Medicare payments. I mean, that's significant. So anyway.
Question on the administrative burden. I think, people may not understand what is required administratively throughout the year for allergists who are reporting or who choose the EQIP path.
Yeah, so I think the lift is very minimal. It really, the biggest lift is just this actual enrollment period. And essentially we need a lead provider to initiate the process, and then you could, get someone else at administrative personnel in your group to finish it up. But outside of the enrollment process, there's no additional reporting burden. We, of course, will have, baseline and performance reports available for you to review. Some of our groups do a ton of analytics. Some of them look at it to monitor the performance. It really depends on the level of resources that you all have. But after the enrollment period, we need a signature to finally have someone participate and for them to sign in. But after that, again, the individual providers participating have really no additional burden in their participation.
The only thing that you might have to do as an allergist, a large number of the allergists, particularly the smaller private ones, are not connected to CRIS. They're connected to CRIS through the PDMP, but they're not connected to the HIE, and you'll need to be connected as well. But MedChi has 5 staff people who do that and help you do that, and we can walk your practice through it. If you're already signed up, then you're fine. So essentially, you'll have to just fill out a very easy form. And I've got to say that I got to give the CRISP and the HSCRC credit. This is a much easier form than the Maryland Primary Care form, which was developed directly by CMMI, which is very complicated. This one's not hard to do. Or you can join an EQIP entity and they can load your NPIs. But once you fill that out, you'll have to sign up for CRISP, which we can help you do as well. And then you will have to you'll have to sign a participation agreement. But that's really it. I would suggest that it does make sense, though, to actually try to be successful and look at it, because if you can hit shared savings, that's another pot of money. So, you get to avoid MIPS, you get the APM bonus, which is more than a MIPS bonus, even if you're a complete rock star. And then on top of that, you have a kind of a lottery ticket for shared savings. So that's kind of the benefit. And I've got to say, because we've been so lucky to have physicians involved from the very beginning of the development of this, I think a lot of the other problems we've seen with the national APMs are not here, because really, and I got to give Will and the other folks at the HSCRC and Jessica and their predecessors, Maddie and others, a lot of credit. We've had physicians involved in developing these from the very, very beginning, and they've really thought about things like administrative burden and ease of getting involved and alignment. And you can see that when you see how it was developed.
And Jean, just a point of clarification, this would be for the year 2024. So I believe the APM bonus is not in place in 2024. Is that correct?
No, it's 3.5 for 24. It's not in place for 25, okay. I think.
25.
Yeah, Jean, I don't think so. I'm sorry, Jennifer. I'm pretty sure that there's no bonus in 2024. That I know the AMAs, a lot of, and we are, making comments and stuff, but it's scheduled to go away at the end of 2023.
No, Will,
we can talk offline.
Yeah, well, that's important.
Yeah, I think the AMA actually convinced Congress to do it. So
yeah, it's done. It got done.
I don't think so, but okay.
Oh. Well, it does say on the CMS website for 23, it's 3.5. I thought it was done too. I thought the AMA had worked it out.
No, I don't believe so. I followed it pretty closely.
All right. So what does that mean? Does that mean that?
Well, there's still, I think people are making, the AMA, and we're going to be making comments, hoping that we can get that 3.5%. But the other thing is the difference in the conversion factor for 2024, beginning in 2024, the conversion factor, you get a 0.75% increase. Mm-hmm. If you participate in an advanced APM versus a 0.25% increase if you don't, if you're in just MIPS or you don't participate in anything. So that's something right there.
Yeah, and I'm looking on the CMS website while we're talking, and it does look like you're right. But I was under the impression that was done, but maybe it's not done. Maybe it's one of those things where they believe it's politically done. But we'll follow up on that. I still think there will be an APM bonus, don't you?
I actually don't. I'm hopeful, but I don't know.
Okay.
Yeah.
Well, the good news is that if they don't do it, you can drop out and do MIPS if you'd rather do MIPS.
I mean, I know, but I think even without the 3.5% bonus, there's so many advantages to EQIP though. I mean, you know, you get the conversion factor thing, you can avoid the MIPS. MIPS is a huge administrative burden. And I mean, it's just a pain and it's risky. You have a 9%, you're risking a 9% penalty. And it's, as Dr. Dixit said, it's, you know, it's becoming increasingly hard to even reach break even. I mean,
yeah, to build on what Jennifer said, you know, your MIPS target in 2021 would have been what, 62%? 62, is that correct? Your target score now?
Yeah, 65% in 2021.
82.
Yeah, going to 82 in 2024. And like, I mean, I do think that like about 30% of allergists are at risk of getting a negative, pretty large negative payment adjustment. So this is a way to avoid that.
I think we're at time now. Of course, if there are any questions, there's some emails you put in the chat. Feel free to reach out to us individually or reach out to any of the emails that we share in the chat. If there are any questions, let us know. Appreciate everyone's time here. I don't know if there's anything you want to add, Jessica or Jean, as we wind this up, or if Dr. Matz has anything you would like to add.
I just put in the chat, if you're ready to sign up, next steps, just email that equip@crisphealth.org and we will get you everything that's needed to begin this process.
And I would just ask that we do it quickly because we're really down to 16 days and, you know, we have some staff people to help us, but really a lot of the work gets done by Jessica. So we need to make sure that if you're going to do this, we get you started. It's not hard, but we want to make sure that if you have a problem or there's an issue or we need to work something out, we have time to fix it.
Yeah, I just want to read, this is a very unique opportunity that exists in your state that does not exist anywhere else.
All right. Well, thank you, Amar, Will, Jean, Jessica, everyone, Jennifer. It's very helpful.
All right. Bye-bye, everyone. Take care.
Have a great evening.